This session is going to be around nurse clinics, and we're very lucky to have Dr. Richard Hatchett to share his experience with us. Richard is a nurse tutor from London, and he's going to share the UK experiences with us by exploring the wider factors that appear to push this form of healthcare delivery and assess clinics' effectiveness and the role in modern healthcare. So he's going to outline the areas which help a clinic's development, such as a good business and operational plan, and make the case for evaluating patient experience and not just satisfaction. So Richard has come to Australia last week, and we're working him to death. So if you've got lots of questions for him, he's happy to take questions at the end. And would you please put your hands together to welcome Dr. Richard Hatchett, please.
What I'm going to do with these slides, this is such a big area that we thought we'd take some questions at the end. Otherwise, having sort of done one day of this conference, I know we can get some real questions generated, and we can kind of take up a lot of time. So as you go, if you would like to make a note of your questions, we'll try and get through some of those at the end. And in addition, I'm obviously here over coffee and always happy to chat over this subject, and I certainly don't know all of the answers because it is a big area. What I'll do in this presentation is I'll define a nurse-led clinic from, I think, your perspective, my perspective, but a good essay, a good document always starts with a definition, so we have to start with a definition. I can't veer that much off the tried and trusted pathway, and we'll look at why we should and develop a nurse-led clinic, and I'll base that on what's happened in the UK, and I think it will encapsulate a lot of what we've been hearing, particularly on if you were here this morning, the role of the nurse practitioner and practice nurse, etc. I'll look at the UK experience. We have a huge number of nurse-led clinics with quite high autonomy amongst nurses, which developed from the late 1990s. We really didn't have clinics many clinics at all. School nurses, diabetic nurses, or nurses working in diabetes, we had a lot of those, but really the scope and the level of practice we're seeing in the UK now in the last 15 years was just unheard of in the 1990s. So I've done a nice little, what I call a bubble diagram of the key pushing factors. Yes, it is the other side of the world, but as this morning, if you were here, we were looking at international trends and developments. It's always good to look elsewhere to see what has enabled these developments to occur. I'm going to touch on the evidence. I probably won't go on too much about that, but I've given you quite a number of slides on that, and I'll just put some key messages forward. And I've given you what I consider to be some of the best documents, the best research in this area. Some of it isn't directly nurse-led clinics, because there isn't a huge amount out there, but some of it will be doctor-nurse substitution and so forth. I've tried to focus on primary care. Not all of it is bang up to date, because I've looked for the best rather than, it must be in the last few years, etc. So that's useful if you're having to put together a business case for a clinic, a document, a review, whatever. That's kind of done some of the work for you. I've also chosen documents which are more easy to access, i.e. Free to download online, so because there's no point in showing you something from the Outer Hebrides Nurse Practitioner magazine and you're saying it looks great but we can't get hold of it. So I've chosen some that are more easily accessible. I want to talk about aims and objectives, but I'm going to frame that within 10 steps to running a clinic based on an article I did a few years ago, because that's quite a useful checklist, simple checklist of things that the literature, the experience of nurses around the world seems to show covers most of the things one needs to think about, so that you're not firefighting as you go, so sort of pre-planning. So there we are, the 10 steps to an effective clinic, or that's the aim. Then I'm going to touch on organisation and wider culture, and that's been touched on a lot in this conference, and as we all know, particularly for me coming to Australia, I can see it because I don't live in it. Sometimes that's easier to do. And as with many of you, I've worked in so many different settings, private healthcare, academia, the National Health Service, and culture is so powerful. So I'm going to suggest to you two tools which will particularly pull together a lot of what Stuart was saying in his sessions yesterday, was it? It seems like a long time ago, yesterday. And that is the cultural web and the force field analysis. You may have heard of them, it may be a revisit, but they're quite useful practical tools to put into operation a lot that's been talked about, and they're incredibly, I think, important when you're pre-planning or planning to put a clinic together. So I better just tell you a little bit about who I am. That's where I work, and that's the Royal Marsden Hospital in central London, in Chelsea, and that's where I first met Lynn, in the cafe opposite the hospital. And we have two branches, one in Sutton down in South London and one in central London. And William and Kate are the patrons, so they're often near to where they live, and you're often seeing it's a high-profile hospital and a registered charity. What's interesting about the hospital, and I'll come on to the changes in primary healthcare to give you a bit of context in the UK, is we now employ community nurses in the last year. I'll come on to that, but it explains a little bit. So we're now the Royal Marsden Hospital and also incorporating Sutton and Merton community healthcare services. Sutton and Merton is a geographic area of South London. So we employ heart failure nurses, HIV nurses, district nurses, podiatrists, all allied health who work in the community. Not practice nurses because they're linked to, obviously, the same model to the GP practices, etc. But we have a number of nurses who go out and provide community services, and that's quite a new thing, but I'll explain a little bit about that. And that will help to explain the context of the clinics as well. So let's start with a definition, and it's kind of playing games a little bit because they're very hard to define. A few years ago I was involved in, as a nurse setting up a hospital, the Heart Hospital in central London, and we had a wide variety of nurse-led clinics there, all of them equally important, but some very advanced practice and some not so. So we would have pre-admission clinics where patients, I'm sure familiar to people here, would come in a couple of weeks before surgery, and the nurse would check that the bloods had been done, an x-ray had been done, dietetic assessment and so forth. But it was in no way could be described as advanced practice, but it was very, very important. So calling nurse-led clinics a pure demonstration of advanced level practice just doesn't fit completely in the definition. Clinics encompass a huge array of skills, ability, but all are equally important because they're all there to meet patient needs. So we could say a nurse-led clinic is where the nurse has his or his own patient caseload. The service often involves, not always, an increase in the autonomy of the nursing role. The nurse-led clinic requires the patient to fit into a time slot, often through an appointment system. Not always true because we have drop-in clinics in the UK, as you may or may not have over here. So it might be, as I'll talk about from my own research, might be a diabetic drop-in clinic where patients who are struggling with their diet and medications, etc., every Monday and Thursday can just come without an appointment to a drop-in service. So it's not always through an appointment system. There is the ability to admit and discharge patients from the clinic or to refer patients on to other more appropriate healthcare colleagues based on the nurse's own assessment, which we've always done in our careers anyway, so it's not unique. I do include that because the ability to navigate and negotiate with other allied professions, to accept your referrals, to accept your request for x-rays or blood tests, etc., is critical. And we call them nurse-led clinics, and I know here it's more nurse clinics. And in the UK, some nurses don't particularly like the title nurse-led because it works within a team. A nurse-led almost implies the nurse and their own abilities, and they can move mountains. Of course, it works within a team. So some like nurse-managed clinics, some like nurse clinics, etc. So that's kind of roughly what we're talking about, but my argument is that it's not always easy to completely define the clinic, but hopefully that's what you think we're talking about, and nobody's got up and walked out, so we're obviously roughly on the same page here, so that's good. Okay, so why develop a nurse-led clinic or service? And let's put all of these up because quite a little bit to go through. There is an awful lot of literature on nurse-led clinics or nurse clinics, but still a lot of it is descriptive. It's sort of a two-pager in some of the nursing press where Mary Jones, the nurse, describes what she does in the clinic. And to me, that's, of course, interesting. It publicises, it gets the message out of what's happening in the profession. But it doesn't necessarily tell us what the pushing factors are, the boundaries, and how we've got to where we are. So I'm always interested in good quality research in this area and to be able to demonstrate measurable effectiveness. So with all the literature together, these are some of the main reasons why you might develop a nurse-led clinic or service. The first and the last ones are particularly important for the UK perspective, as I'll talk about. So it can be to increase patient access to appropriate healthcare personnel. In the UK, that phrase emerged in the late 90s, as opposed to doctor, nurse, etc., and the division of labour being very sharp and clear. So it was to appropriate healthcare personnel. So it was opening up the doors a little more for nurses to expand and change their scope of practice. I'll come on to that with some more slides. To help educate the patient, obviously, as we've said, and you're experiencing over here, an ageing population and a population of increasing chronic ill health. And kind of we don't cure a lot of people really. We're improving quality of life for people, maybe giving some years to life, but importantly helping people to manage and have a good quality of life, manage their illness. And psychological support, and importantly in the clinics in the UK to monitor the patient's ongoing clinical condition with the aim to prevent hospital readmission, to prevent deterioration and to improve quality of life. To empower the patient. This has often been quoted as a cornerstone of healthcare policy in the UK and has been for some time, that the patients take more responsibility for their healthcare so that they can manage their condition more effectively and obviously, as we've said, have a better quality of life and to reduce costs on the healthcare service, hospital admissions and so forth. So to empower the patient is often seen in aims and objectives and particularly seen in British healthcare policy. I often say about empowerment, it's an interesting point because empowerment is almost a philosophical perspective. It's a move that you want to move that you want to take the patient in, that they take responsibility. In the UK, we've had the expert patient programs where patients with chronic ill health such as diabetes, heart disease, etc., have come in for courses and sessions to learn more about their condition. They educate other patients, rolling out better management. So patients have been involved through the expert patient programs on supporting other patients in their community, and that's been a program that's been around for a while. So the whole gamut of empowering patients. Now, some patients may not want to be empowered, and that's kind of the point I want to make. And some people here, probably a lot of people here, will remember the old conceptual models of nursing. Orem was one of my favourites because when I did a master's in the 90s, I did an essay on it, and then although they kind of disappeared in the UK one weekend, they just sort of, suddenly we were onto integrated care pathways, and we just don't use really models as we used to. They used to frame everything. And Orem, if you may remember, Dorothea Orem, an American, was a manager and educator, and she produced her first model. It was adapted many times, but in 1959, the late 50s. And she wanted to find, particularly for financial reasons, a clear definition of what nursing was. And many will remember that she defined that through self-care, that the patient would be able to self-care, that naturally we get ourselves up and dressed and washed and out there, and that we constantly move ourselves towards self-care. Therefore, the role of the nurse is a legitimate one when the patient cannot self-care, or their family or significant others can't self-care for them. So if you broke your leg, for example, that would be an example where you couldn't self-care, you couldn't mend it yourself, so there's a legitimate role for nursing. And that meant when you worked with your patients, you constantly moved them forward to self-care. And I worked in paediatrics in the early 90s where it was actually one of the few places I felt it worked very well. So for example, at 3 o'clock in the morning, you're on night shift, if the mum said, oh, could you feed the baby for me, etc., we would, unless they were very tired or exhausted, etc., we'd say, no, we'd like you to do that because we're moving them towards self-care, or the family or carers to self-care for the patient. And it worked very well. But Anna et al. In 78 and Malise some years later looked at that model, which essentially to me is an empowerment model, in a care of the elderly home and with Middle Eastern men who were in America slight generalisation, but Middle Eastern men in America without their family, and found that they were resistant to self-care. And particularly in the care of the elderly home, yeah, I can probably self-care, but, I'm 95 and a half, and, just tell me what I need to take and, this type of thing. So I always say there's sometimes a slight tension there between patient-centred care and we're going to empower you. And it's just a thought whenever I speak of empowerment, patient-centred, but you're going to be empowered, but that's our philosophy, etc. Whose philosophy is it, etc. So sometimes we move patients in directions, and we also say we're patient-centred. And to reiterate that point, I was speaking about this last week. Before I got on the plane, I went to the GP practice where I had to wait an hour and 15 minutes I'd moved, so I had to go to a new GP practice. In the UK, you are registered with a GP practice in your local area. You can't go anywhere. You have to. You can with a dentist, but you can't with a GP. You have to be registered within your local area. So when you move, you go online to see what practices are in your geographic area and what are not. And then you ring up and say, are you taking NHS patients? Yes. You go along, etc. So I went along to get the odd repeat prescription, the Ventolin, and all the things that people of our age have in the pocket, etc. And waited an hour and 15 minutes for a GP to just say, what are you on? There you go, And it just was such an ironic thing, because there was a clear example of how multidisciplinary working could have made that so much easier for everybody. But while I was waiting, there were two posters on the wall, and one of them said, which we have a lot of in the UK, please don't abuse us, we're here to help you. One of those, with the, don't be horrible to us, basically, we're trying to help you, And so we're here to help, we're patient-centred. And next to it was a poster that said, please remember, I'm paraphrasing, but it was the gist of it, there is only 10 minutes per appointment, therefore we can only deal with one of your problems. You will need further appointments, or we can only deal with one or two problems within the 10-minute slot. And there was the irony of, don't abuse us, we're here to help you, and then, but you can only have one problem dealt with. I mean, I should have taken a little picture, I could have showed you it. So sometimes messages, control contradictory messages, and we'll look at that shortly. To more appropriately utilise staff skills, which I was saying, and particularly in the UK, to offer more equitable evidence-based care, which I'm going to come on to. So I didn't do too much of this in previous presentations since I've been here, but I've been asked just to say a little bit, one slide as to how primary healthcare works in the UK, so that you get a bit of a context. I'm not sure how relevant it is, but colleagues have been asking, so I'll say a little bit about it. We're nationalised. We've been nationalised since 1948, and about 90% of healthcare is through the NHS, and 10% is through the private sector, Bupa, which I know you have here, PPP, HCA, etc. In the community, more recently, through a 2010 Act, we have clinical commissioning groups, CCGs. They've been in existence for a year. If anybody's worked in the UK more recent years, prior to that we had primary care trusts. And clinical commissioning groups are GP-led, which has obviously led to a little bit of, quite a lot of unhappiness amongst nursing colleagues, because the commissioning is now led by GPs, and we've been moving forward so much in the last 15 years, so we would have liked it to be more multidisciplinary. In a geographic area, and there are 211 currently clinical commissioning groups in England. Wales, Scotland and Northern Ireland have health boards and slightly different systems, although they've undergone change in more recent years. The clinical commissioning groups will commission, obviously, the majority of the services for their geographic patients, based ideally on population health analysis, etc. We know, of course, in reality, it doesn't always work so perfectly. This meant, prior to that, that the primary care trusts employed nurses within the community and also commissioned and provided the services, so it's a slight tension there. So now the clinical commissioning groups just purchased the services, and there was a group of nurses who were homeless, that is those district nurses, as we said, other colleagues, podiatrists, heart failure nurses, HIV nurses, musculoskeletal nurses, etc., those who were not attached directly to GP practices. So they're now employed by the acute hospitals. So slightly unusually, although it seems very successfully, the Royal Marsden, an acute specialist cancer hospital, employs nurses who work within their nearby geographic area, Sutton and Merton Community Healthcare or Healthcare Services. Clinical commissioning groups, we've had a recent paper, and I can, if people are interested in commissioning, I can get that reference for you, that's looked at clinical commissioning groups, or commissioning, I think about 2 or 3 years ago. And the idea behind these is it's going to be competitive, or is competitive tendering, that those who can provide the services will be bought. And we have Virgin Health in the UK now, which emerged in 2012, providing at least, I've probably got this wrong while I'm being recorded, at least 4 services. Musculoskeletal is one, services in the community, and sexual health services. Somebody said that was entirely appropriate for Virgin Healthcare. Sexual health services in Teesside and near the Scottish border, but it shows how different companies are coming in the UK. But this particular report showed that often this purchaser-provider split, in reality, we work much more closely with our acute colleagues, community colleagues, etc. And often decommissioning or taking away services doesn't happen as quickly as within a year. Often colleagues will say, well, let's give you a little more chance to improve that and so forth. So it's a slower process than perhaps the ideal of, or the idea of purchaser-provider. But the GPs, there has to be a nurse on that clinical commissioning group, but they purchase services in the UK and England. The other, if you work in the UK in primary care, you hear all the time the QOF points, Quality Outcomes Framework. That emerged in 2004, and it's a payment for performance system. When it first came out in 2004, there were just over 1,000 points that were available. It's got less, and each year they release the points that GP practices can get. And these are targets, as you can imagine, that are time-related and percentage-related. So it's in your GP practice, the percentage of patients with coronary heart disease who've had a cholesterol within the last so many months and so forth, number of asthma patients who've been recalled and gone through their inhalers, etc., heart failure patients on a beta blocker, these sorts of targets. A very recent review looked at the effects of this both on patients and on the nursing profession, and it's debatable as to what the QOF points have done to nurses running clinics and so forth. And there's 2 ways of looking at it. As you can imagine, most chronic ill health is managed in the community in the UK by nurses, so they're the ones who are achieving the points, although the remuneration doesn't seem to filter through to the nurses who are collecting the points. It could be argued that it's increased the autonomy of nurses within the UK, because to achieve those points, we've had to change the way we work in the community, and so nurses run a lot of clinics to achieve those targets. But also nurses are saying that it is pushing them towards task orientation to achieve those targets. It also mitigates a little bit against certain groups, such as the housebound patient, for example. It's the patients who come into the clinics, who come into the GP practice, etc., who meet the targets and so forth. And of course, as we know, and I'll mention a little bit later, I'm sure, that there is also exception reporting, whereby some patients can be excluded from the figures you put in, because it may be that although they perhaps could go on a tablet, they don't because of side effects. They don't want to take any more tablets. They may be terminally ill, for example, and it's not going to be of no major benefit. So there is exception reporting, because outcome frameworks and targets are based on the ideal and the average patient, and we deal with the real patient, etc. But QOF points, you hear a lot of that, and it increases income generation for GP practices. And but there's always a question as to where that funding actually goes. In the community, healthcare trends, always moving the hospital out into the community and upskilling the community colleagues. We have community matrons who are usually highly skilled, often working at advanced practice level, nurse prescribers and so forth, to help coordinate and work with the teams to increase the quality of care given to the patients. And we have a lot of a phrase called hospital avoidance. We have hospital avoidance courses, and that is where Community colleagues come in particularly to look at what we call red flags, which is a common term within nurse practitioner programs, those points where the patient may deteriorate, needs that extra help, etc. So what are the warning signs and so forth. So the aim, as I'm sure in Australia, is that patients improve their quality of life but also can stay in the community and stay at home. There are a number of other trends, but I won't go into all of those, but particularly seamless care is another one between community and hospital and so forth. That's been around for quite some time. Types of nurse clinics we see a lot. I've divided it into location, the type of nurses and the level scope of practice. GP practices, we have NHS walk-in centres. They're nurse-led walk-in centres we've had since 2000. They are in town centres. They can be in the car park of a hospital, in the corner of a hospital, etc., shopping centres and so forth. And NHS walk-in centres are kind of running from early in the morning till late at night. They are nurse-led. Sometimes they have GPs for a couple of times a week, etc. But nurses, they're not always nurse practitioners, but looking at UTIs, chest infections, contraception, those sort of minor ailments, etc. And they were particularly developed to increase access for patients in the community services where GP practices were rather rigid on their time frames. So out of hours, basically out of hours. And also to reduce the patients who were going to emergency departments with things that really weren't an emergency, basically. So that's particularly grown. Outpatients, we're seeing a lot of nurse-led clinics out in the outpatients, some very specialist. I'm cardiac by backgrounds, arrhythmia management, through to our more familiar diabetes, cardiac clinics, etc. Those nurses also go out into the community, so we see clinics run in all sorts of areas. I put community centres there, etc., in all sorts of locations, school nurses and so forth. Nurse practitioners, a point of interest, some of you will know we're one, well, you saw if you were here, if you were in the main session this morning, that we don't regulate nurse practitioners in the UK, and it's not for want of trying and wanting to do it, but we don't regulate. Any nurse, I haven't met a nurse practitioner in the UK who doesn't want to be regulated and protect the title, etc. We've not been able to achieve that so far. Without spending 10 minutes as to the story of that, but we do have competencies. The Royal College of Nursing and the Nursing and Midwifery Council have that. So within its master's level, most of the programs are at master's level as per the International Council of Nursing, and the competency framework is within those master's programs. But I could call myself a nurse practitioner, as was said this morning, and not have done any of those competencies. So it's something that is highly desirable, but we haven't achieved that. We could have achieved it in the past by adding an extra part to our register. We were unable to do that for a number of reasons. Firstly, we had a number of high-profile cases, the Harold Shipman case and the Beverley Alec case. Harold Shipman was a serial killer who was a GP, and there was concern about the regulatory bodies picking that up and getting more public involvement on regulatory bodies and so forth. And Beverley Alec was a female serial killer who was a nurse and was killing children in hospital with insulin and all this sort of thing. So there's been a lot in the last, say, 15 years of concern about the regulatory bodies, etc. So we can't change the Nursing Midwifery Council Register and add a separate section without referring to government, so we're unable to do that. So it may become a recordable, but it's not a protected title at the moment. The current government's view as well is you're already regulated. You know, you're regulated anyway. Why do you want more regulation? They're very much in favour of deregulation. And also in the complaints we have to the Nursing and Midwifery Council, the majority are about conduct, not competence. We have very few complaints about nurse practitioners. Why do you want to further regulate? There's a lot of arguments on both sides. When I teach that to our master's level students, I try and get them to see both sides, because the general argument amongst nurses is we want regulation. And my view is not that important, but it's always important to see both sides. Level and scope of practice, nurse practitioners certainly, and practice nurses. A lot of nurses run clinics. The nurse practitioner, as was discussed this morning, is defined by the level of practice, not the scope of practice in the UK. So it's an advanced level. You could have we have a lot of CNSs, clinical nurse specialists. It's an unregulated title, but they are of varying ability. And you could have a clinical nurse specialist in heart failure who runs clinics, etc., but does not meet the nurse practitioner competencies. So a nurse practitioner is generally a generalist in the UK, and emerged from primary care with the work of people like Barbara Stilwell, latterly in America, previously at the World Health Organization, who was a particular leader in nurse practitioners in the UK in the early 90s. But it's a broad, generalist and advanced level of practice. Yes, they specialise, but they're trained at a broader level. But we do increasingly see nurse practitioners working in the hospital setting, as was highlighted this morning at the keynote address. Okay, there we are, something a bit different to look at. The enablers of nurse-led clinics in the UK. I've tried to think of those which, I'm sure there's more, and if you're into all these diagrams, yes, they should overlap, but all that. So how much should they overlap? How big should the text be to demonstrate it? But they're all powerful enablers of nurse-led clinics in the UK. Particularly has been the political push. We're nationalised, so obviously we're driven a great deal, an enormous amount, by the Department of Health. Okay, what happened in the late 90s, and I think the message here is, as I think has come through the conference, is we need to canvass, we need to be political, we need to make sure that we're demonstrating our effectiveness in all of our work as nurses. And Lim showed me the document from the Medicare Alliance on how to market yourself. It's incredibly important to show what we're doing and be positive about it. What was happening in the 1990s was a number of things that came together, and I'll include this in nursing profession as well. In the UK, we had been in the university sector since about 1991, so we were able to move away from just a rather static registration, which was national but not academic. Once you're in the university sector, you're able to create courses, have much greater flexibility and demonstrate academic level. And we weren't able to do that before. So where we were starting to change the division of labour and bring in nurse practitioners and upskill all sorts of nurses, practice nurses, district nurses, etc., we've got a responsive university sector, a huge network of universities able to support that. We had an awareness, obviously, of evidence-based medicine and nursing in the 90s. I'm a cardiac nurse, and for example, in the community, we knew at that time that if you had a myocardial infarction, you needed to have oxygen, nitrate, GTN, and aspirin. I got all four. I haven't been able to do that last week. So I got all four. So we knew that. Yet we had a postcode lottery. We knew in the UK that some people got it and some people didn't get it across a whole range of conditions, etc. It depended on the skill of the nurse, what the GP was interested in, this type of thing. So there was a concern of raising the standard of care, evidence-based, but also making it more equitable across the UK. The only way we were able to achieve that, in addition to reducing waiting lists, was to change how multidisciplinary practice worked, and to stop this rather rigid division of labour. Waiting lists, as a cardiac nurse, you waited about 18 months to have your coronary artery bypass grafts done. It was a long wait. Got it down to about 3 or 4 months. Through a lot through the nursing profession, it really was. So it's been highly successful in that sense. So political, there was a push at the time, and I'll show you some quotes from that at that particular point. So we had education, we had nurse prescribing was bubbling along. Our first report on suggesting it came in 1989, and gradually and more recently we've got nurse, but we have about 60,000, I'm probably not quite right on that, about 60,000 what we call non-medical prescribers in the UK. So we have, provided they've done the training, we have dentists, we have physios, we have pharmacists, and we have nurses. It's quite tightly controlled, obviously, and you have to make a case for becoming a nurse prescriber. You can't just decide to do it from your employer, and regionally you have to make that case. But now nurses can prescribe from the same formulary as medical staff within their scope of practice. And in terms of conduct, we've had very little problems about that, although it's obviously quite controlled. So that's available. So a lot of these things were occurring at the time. I put allied professionals there. Some resistance from dietitians, for example, who weren't really prepared to accept referrals from nurses, though we've negotiated that. Radiographers who were concerned about ordering x-rays. We have the ionising radiation regulations, which state that nurses can order X-rays, providing they've undergone training to understand the risk of exposure to radiation and so forth. So, you know, it's worked fairly well. Let's go through some of those rationale. So the Labour government of the 1990s were a clear supporter of nurse-led services. They talked at the time in their document for reforming the NHS, they talked of nurse-led services to provide health information, self-help and minor treatment. So small to start with, but gradually growing. And Tony Blair, remember him? He talked about stripping out unnecessary demarcations. It's about division of labour. Introduce more flexible training and working practices and ensuring that doctors, still rather medically dominated at that point, that doctors do not use their time dealing with patients who could be treated safely by other healthcare staff. So a big political push. So the importance of our colleagues, Dame Sarah Mullally at the time within the Department of Health, and all those wonderful people, Marie Barnett, who represented cardiac nurses, was a New Zealand nurse, all there pushing forward for changing scope of practice and changing division of labour. And Alan Milburn, who was our Secretary of State for Health at the time, at the Royal College of Nursing, which is our biggest union and professional organisation for nurses, in 2000, he talked about or introduced the Chief Nursing Officer, Dame Sarah Mullally at the time, her 10 key roles, which included managing patient caseloads, running clinics, prescribing medications and treatments. We hadn't got nurse prescribing at that point, but it was a driver. And Milburn said he wanted to liberate nurses, which is really nice. Equality between professions, that's what I want to see, not nurses versus doctors, but nurses and doctors working together, each contributing their unique skills to a single care system. So it was palpable at that, palpable at that time. And then we had, which is a point I haven't raised, we had a number of key documents called National Service Frameworks, which aimed to address this postcode lottery and raise the standard of services provided in community and in hospitals. The first was coronary heart disease, and we had respiratory, paediatric care of the elderly, mental health, etc. And although there was some resistance at the time with the idea, you know, please don't tell us what we should be giving our patients type thing, they were saying in quite clear presentation, if the patient has this, they were guidelines, not protocols, if the patient has this, unless there's a good reason, they should have this medication, that medication, and so forth, evidence-based practice. So cardiac to start with, if somebody's having an MI, they should have this, the heart failure, they should have that, and so forth. And again, to be able to do that, we needed to change the division of labour. Now, example of a nurse-led clinic that developed at that time were our rapid access chest pain clinics. So community colleagues would see patients and they would suspect maybe that the patient had symptoms of angina, stable angina, not unstable. And the target, if I'm correct, was that they should have a definitive diagnosis within 2 weeks. So the NSF would give you examples of services, good practice services around the country of how to do that. And a lot of those rapid access chest pain clinics became nurse-led. So they would run, say, on a Monday and a Thursday at the hospital. In the community, you'd fill out a standard form, fax it through, say to the patient, I can't remember how an appointment came through, but the patient would go a couple of days later to the hospital and they'd say, oh, Mr. Jones, yes, and they'd do a 12-lead ECG, and the nurse would order a treadmill test and you'd get a definitive diagnosis, and often the nurse would advise the GP, etc., what medications, and back they'd go and so forth. So that had to be, although the example in the NSF from New and General Hospital was in fact medical-led, they became nurse-led to meet these needs. So that's what's happening in the UK, kind of in a nutshell. Let's give you some evidence for nurse-led clinics that I think will be useful to you. I can't go through them all one by one, otherwise we'll be here all day. But here are some, when you get the slides, etc., that I think are some very good examples internationally, some older than others, but I've gone for what I think is the best quality. I'm going to look at 2 examples, a paper by Laurent, which is a Cochrane review, and a paper by Van Loon, which is a Dutch study on primary care, which will be useful. I've chosen some of these, interestingly, came from the British Medical Journal, which is kind of like the GP's journal, but that's where they emerge. But also you can get those free online. BMJ Archives is open access, so you can get those quite easily. The one that's quoted a lot is Horrocks, looking at primary care clinics and doctor-led clinics, etc. And there are others that are of relevance. I put the Parker paper there, which Lynn actually gave me when I arrived in Australia, because I think that's an interesting one. It kind of, I didn't quite know where to put it, but it was such an interesting paper to read. And this is about looking at what Australians will accept from nurse practitioners, and I think raises some interesting points. 1,734 members of the public, 71% or approximately were women, and they were asked to list what they, or tick or whatever it was, whatever they would accept from nurse practitioners in the community. And what's interesting about this is that a high percentage said that they would accept nurse practitioners doing a clinical assessment, a health assessment, taking a history, so forth. But a much lower percentage in the 50s would accept nurse practitioners making a diagnosis through diagnostic tests. Well, many here will know that the most complex of those skills is taking the history, not actually, well, they're all complex skills, but that's the most complex. And possibly most texts will tell you that 80% of the diagnosis can come through a good clinical history and so forth. It's a complex skill. We teach that at the Royal Marsden. And it shows that sometimes the public don't always know, what they don't know. And there's an education role there, as we've been saying, all through the conference, about what a nurse practitioner and a practice nurse does. And it's a wonderful study, but it's interesting what people are perceiving from a public perspective are the easy tasks, when in fact in the profession we know what actually are the more skilled and complex tasks. So that's a very interesting paper to look at. Couple of points I want to make without drumming on about evidence in nurse-led clinics. Sharple said there's little difference between nurse and doctor-led services for managing respiratory disease. I'm quite happy providing the services are equitable. Always you're going to find we excel with nurse-led clinics against doctor-led. It's not a competition. It's just looking at what might be best for the patient. You don't want to be giving inferior services. You want them to match. Having said that, I don't always want to think of nursing as a substitution for doctors. It's about being a maxi nurse, not a mini doctor. And people like Kim Manley from the RCN have written a lot on what are the nursing values. Are we in fear of losing those? But also, we were talking about this at the conference, I think last night we were talking about it, that this process of skills being taken from doctors and given to nurses and so forth is something that's always gone on. The change is always there. In the UK, there was a writer, Margaret Broadley, who was the matron of the Royal London Hospital, which you'll know if you watch Call the Midwife. That's the hospital, and the big hospital in the East End, between the wars, between the First and Second World War. And she wrote two very entertaining biographies, Patients Come First and Patients Are People, in the 1980s. And she trained from 1921 onwards and lived to a great age. She was nearly 100 when she died, not that long ago. And she said, in the 1920s at the Royal London, we did not take temperatures. The thermometer belonged to the doctor. The doctor took the temperature, not the nurse. And so that process accelerates, slows down. And now in the UK, I'm sure over here, it's our healthcare assistants who take the temperature, the unregulated, skilled but unregulated workforce. So, that process has always been there. It's just sometimes accelerates, sometimes slows down. But importantly, Sharple said nurses were more costly initially. I've seen that. I've only seen that in, I think, two other papers. I think one was a Portsmouth paper on arrhythmias, but don't quote me, but certainly one was on epilepsy nurse-led clinics. Nurses are more costly initially. Well, that's something I think that needs a little bit of research, because you want to know why. Is it because they are ordering more investigations? Well, clearly, and they're more nervous, etc. What is it that we can do to support our nurses so that they feel, if that's the reason, I don't know, that they feel more confident and competent in their skills rather than having to order more investigations? Is it because we, certainly in the UK, although it's changed now, had rather a punitive profession? If you gave an aspirin 5 minutes out of when it was prescribed, you were up, in front of the Director of Nursing, etc. And we've learnt much more to move towards, like our aviation colleagues, to learn from near misses and near mistakes, not to punish all the time, because that tends to sweep things under the carpet and that sort of thing. So maybe things will change, but I would be saying, instead of saying, oh, they're more costly, why? What is it? Can we do clinical supervision, mentoring? What kind of support can we offer to reduce that issue? Just from the BMJ, an interesting point about little evidence to date to support the widespread implementation of nurse-led management interventions for COPD. Sounds negative, but the point here is the data are too sparse to exclude any clinically relevant benefit or harm arising from such interventions. 9 randomized controlled trials, but most had some potential methodological flaws. What it means is there's little evidence because we haven't really measured it or found it yet, and we need good studies. We've got academic colleagues here, practice colleagues, the call goes out for some good studies, and even the ones they looked at there had methodological flaws in them. So we still need ongoing research to demonstrate the benefits of our clinics and nurse-led services. It's out there, I'm convinced it's out there, we just need to measure the right thing and get it out. The 2 papers, both are free online. I don't think the Van Loon is actually, I may be wrong. Certainly the Laurent is. The Cochrane reviews, and I'm sure you know over here, are highly regarded reviews of academic papers. And they looked at 16 randomized controlled trials, looking at over 4,000 papers, sifting it down to what they thought were the best, that looked at nurse-doctor substitution in primary care. So some running clinics, some not, but some activity that was doctor-nurse substitution. I think in at least six of those papers, the nurse was the first point of call for the patient when they came in out of interest. But they said patient outcomes are similar for nurses and doctors, but patient satisfaction was higher with nurses. And they concluded appropriately trained nurses can produce as high quality care as primary care doctors and achieve as good health outcomes for patients. It's a very useful one to quote. They said there was a varied effect on direct cost of care and doctor workload. The doctors weren't sitting there doing nothing, and that's good for us in the UK because that means that the doctors, yes, there's complaints about, oh, am I going to lose the ability to see the more regular patients and the skills and the medical students, etc. But doctors have been very supportive and generally very pro nurse-led clinics in the UK generally. That is something I can't give you the clear answer as to why, but certainly we've been short of GPs, that may be one reason. It may be they're able to move on and do things that they want to do, etc. And this demonstrates no direct varied effect on doctor workload. So they weren't sitting there thinking, what am I going to do because the nurse is doing everything, they're nicking all of my work, etc. That wasn't what this study is saying. But it did say nurses took longer, gave more information and recalled more, and that's the Cochrane review, not my conclusions. But they said do view with caution again, as it's difficult to compare outcomes across studies because they're so different, and many studies had methodological limitations. So again, the call for good quality research comes out there. Just the Van Loon study, Dutch study from 2009, interestingly, cardiovascular risk, 615 patients in 25 practices, looking at nurse-led cardiovascular risk clinics where the nurse was communicating risk. I've had to summarize it in a little slide. It's obviously a big document. Lifestyle changes and motivational interviewing. They said there was no real change at 1 year compared to controls. In one subgroup there was a significant change, and that was in patients in a small subgroup consuming fruit and vegetable. That went up. But again, it's comparable, and that's good. That is good. Having said that, they looked at 4 areas, if I'm correct, and that was alcohol consumption, smoking, exercise and fruit and vegetables, and it was self-reported from the patient. So, there's some faults in that method. In the UK, we do our health surveys every year. About every 3rd or 4th year we do cardiovascular, and there are nurses who take bloods for cholesterols and saliva for whether they've smoked recently, and it's regarded as a higher quality methodological study. Here, not knocking it, but it was self-reported, so you have to look at that within that context. So, many studies show that interventions generally, and nurse-led clinics included, can improve care. But we have to think as well how generalizable these studies are, because is it in the nurse-led studies, it's a real enthusiast, etc. Not that you're not, but your context will be slightly different. So we have to say, does it generalize to other nurses in other settings? And of course, is change sustainable? So it's important to think about that. Okay, just as we move on, I'm going to frame clinics and how we set up clinics and so forth within 10 steps. Now, my interest in nurse-led clinics originally emerged from research I did in the late 1990s as part of a master's at City University in London. And because there was a palpable emergence of these clinics, I looked at this and I used a mixed method approach, not huge, as we know when you do a master's, sometimes you've only got 9 months to do it. It's not a big study. But it looked at nurse-led clinics within the community and hospital as well. So I'll quote some of that as I go, but I'm not going to do slide after slide on that. And that led some years later to the Nurse-Led Clinics Practice Issues textbook, which is still available. As with a lot of these textbooks, it's not going to be even the local bookstore necessarily, but Amazon and so forth. It's an interesting book in the sense that I brought together colleagues at that time, a nurse who was running a contraception, family planning nurse-led clinic, cardiac, diabetes, to talk about their experiences within a framework of how it was set up, etc. And it looks at professional development. And there's a very good chapter there by a lady called Emma Pennery, who at the time actually was at the Royal Marsden, and she was doing a doctorate looking at breast care clinics, doctor-led, nurse-led, comparing, etc. But she does an excellent toolkit chapter on all the different methods you can use to measure the effectiveness of your clinics, the pros, the cons, the quantitative, the qualitative, patient experience, quality of life, and so forth. And she wrote the chapter for this book that I did. I've never met her, and I wouldn't know her if she walked in. And it just shows the wonder of the internet and emails. But she was able to write this chapter, and I wouldn't. I do know what she looks like actually, but I never met her. And just another example of a wonderful nurse who was able to produce an absolutely brilliant chapter. But I never had to meet her. And I don't think I even spoke to her either. I think we did it all by email. She's a pretty remarkable lady. So when we look around our 10 steps, we think about our aims and objectives, critically important aims and objectives. When I've done workshops with Lynn last week, when we had a little more time, we did some work with everybody, why is it important to set aims and objectives? And there are kind of about 4 or 5 reasons. One of the main reasons for setting your aims and objectives, that's an overarching aim and then a set of objectives, is so that you know clearly the direction you're going in, and everybody else does as well. Patients included, of course. The NHS walk-in centres, when they emerged in the 2000, they were nurse-led, and that was quite a new concept in the UK. So there was the risk that patients would come in and sit down there for an hour and wait to see somebody and think they were going to see a doctor. So they produced leaflets which said, this is a nurse-led service, this is what we offer, and this is what we do not offer. There were do's and don'ts, so that patients were understanding. Every year, I think I've done for the last 10 years, I chair for a company called Healthcare UK, probably the biggest nurse-led clinics conference that we hold in the UK. It'll be in Birmingham this year. And I always ask the questions from the chair, and I always say at some point during the conference, what was the patient resistance to this? Bit of a leading question, what was the resistance? And patients have been incredibly accepting of nurse-led clinics in the UK, anecdotally, and I think genuinely they have. But what the nurses will say to you is, I get resistance if the patient didn't know they were going to see a nurse when they thought they were seeing a doctor. It's being honest with the patient and saying the next time you come along, you're going to be nurse managed. That means you'll be coming to see the nurse, and the advantage to that is we can see you more frequently, we can spend a little more time with you, we can actually go through with you more holistically your needs and signpost you to other services, but also just check that your understanding of your diet or whatever it is. And they've been very accepting. And even when they say, I had some resistance from 1 or 2 patients, generally they say they were back on board once they realised the service they were getting, and often nurses generally will say they don't want to go and see the doctor. You hear all these sorts of things, how good people do perceive the nursing services to be. So the aims and objectives make it clear to everybody in your publicity, for the team, for the people referring in. And in the research I did in the late 90s, there was a clinic in the East End of London, which was a diabetic dropping service, as I was describing, whatever days of the week it ran. And this was for patients newly diagnosed. It was nurse-run, and it was for patients who'd been diagnosed some weeks, something like 6 to 8 weeks, but they were still struggling to work their insulin pens and diet and so forth, and they would come along and get a little bit of extra help. But they found there that there were 2 GPs who were misusing that service, because what seemed to be happening, what was happening, was a patient would go to these 2 GP practices, they would diagnose what they thought was diabetes and say, listen, I haven't got time to go through all of this in your education, but if you just go on a Tuesday or a Thursday down to the hospital, there's a drop-in clinic, just go there, they'll tell you everything. The nurses were able to speak to those GPs, but it would have been harder if the GP had said, well, what is your clinic? It's not even clear what your aims and objectives are. So because it was clear, they were able to say, it's quite clear what it is, and we don't want to see those patients. That's not what our clinic is about. So aims and objectives will help us to define who's in and who's out, which patients you're seeing and which patients you aren't seeing, and to be strong enough to say, listen, at the moment, yeah, we can grow it, but it has to be this. I need to be effective. Maybe it's only a few patients a week to start with. It's these patients to start with. So it prevents the abuse. It prevents you thinking, oh, is that patient, can I see that? But who's in and who's out? It's clear to everybody. Importantly, it's great for your auditing and your evaluation. Because if I was working with you and saying, let's audit the service, my first question would be, what's the overarching aim and what are the objectives? The objectives may be tied to QOF points, QOF outcomes, national outcomes or whatever. And the aim would be very broad, so it might be to improve the quality of life of patients with chronic heart failure, or to assist patients to self-manage their diabetes. It's a broad aim, and then you've got some specific objectives. You'll do other things, but what are the general objectives, 4 or 5 objectives, etc. within that? So aims and objectives are incredibly important, and there'll be many other reasons for those as well. They're not easy to set either. I sit on the clinical audit committee at the Royal Marsden Hospital, and we have nurses, medics, all sorts, bringing in audits of all sorts, some quite complex stuff with some rare cancers through to the art therapist wanting to see whether art therapy improves patients' pain, all sorts of different things. And nobody's any better than anyone else in setting aims and objectives, and that's our role is not punitive, it's to help. But they're difficult. And also if you set them as a team, then everybody knows and agrees this is the direction we need to be going in. The business case, I'll come on to in a second. There's an excellent document that Lynn and Joe showed me from the Medicare Alliance on, and Lynn can tell you about the availability of that, on doing a business case. And why I'm raving about it is I don't think I've seen a document to guide you on a business case for putting clinics together. I don't think I've seen one. I'm sure there must be around. So I'll go through some headings with you on the business case, business model, but they are adapted from a business model. I've added to a business case for clinics, nurse-led services, how are you going to evaluate? That's not always seen on a business plan in the business world, but it's important to be thinking about that early on. Patient criteria, we said it. Which patients are you going to see and who won't you see? Remember, when you're auditing and evaluating, if you're changing the patient criteria as you're rolling along through the months, that will affect your audit and evaluation. So do consider that, whether you can hive off certain patients, because if the beast is different at the beginning to the end, people will pounce on you and say your results are invalid because your actual cohort is changing as you go along. Haven't got time to look at that, but it's something to definitely be thinking about. How are you going to publicise the clinic? Posters, online, publicising to other people who might refer in, to the public, voluntary organisations, etc. It depends how your clinic's going to run, who's going to refer in, how patients are going to know about the service, etc., and publicising it to your colleagues as well. And location, where is it going to run? I'm a cardiac nurse, and we run a lot of cardiac clinics from the Marsden out in the community, because patients struggle. They can't necessarily drive, and it's difficult to get up sometimes with heart failure, let alone drive a long way to the clinic. Where can it be held that's most valuable to the patients? And I know that there are other factors that will dictate that as well. But also, from a very local perspective, have you got somewhere to run it? Have you got admin support? Are you going to have to work and negotiate with somebody to do the letters and those sorts of things? That's been a big barrier in the UK. Somebody typing up letters, and many, many nurses still, they're 8 o'clock at night typing up their letters and on dictaphones and things, because secretaries are busy and it's been difficult to negotiate administrative support. So there we are. Consider early on what the aim of your nurse-led clinic is. Make sure the objectives are measurable and achievable and add up to the aim, and take time to do it. It isn't easy, and are the aims happy to everybody who is affected by that clinic? Patient representation, of course, consumer representation. Is that what the groups need? Is that what your colleagues want? Because the nurse-led title, again, implies very autonomous nurse. We work as part of a multidisciplinary team, and we're there to meet the needs of our patients. So think about multidisciplinary support, a simple phrase that is very easy to throw out, but it's the whole crux, the culture, the attitude that we've talked about. And what's been hinted at today, which I think is incredibly important and came through my research in the late 90s, and still comes through today. You may have noticed at the beginning of the slides there was a load of pictures along the bottom of those. Those come from a project that I was involved in, a website that we've now moved on to YouTube. If you go onto YouTube and type in nurse-led clinics, there's a channel there with about 40 or 50 clips where I've gone around, or I did a few years ago with the camera, filming nurses and getting them to talk about their clinics. The aim was for those running clinics where they got 5 minutes, they could sit at their desk and just see these clips. And there are two ladies, probably the third picture along, who said, from Dundee in Scotland, and they were able to set up breast care services and nurse-led clinics very successfully. And I said, why have you been able to push forward so long? And they said, because we've worked for years and years with these doctors. They know us, they trust us, and so forth. Those relational aspects, whether you like it or not, are incredibly important. Almost, I'm not saying it's more important than competence, it's not, but it's the reality is that they've worked together and they can communicate very well and so forth. So different ways of achieving multidisciplinary support. And we think back to the 60s and that famous research study on the doctor-nurse game on how communication works. Think about professional development. How are you going to identify what your deficits are if you're setting up a clinic, and how you're going to address those? Within the book, many ways of doing it, there is a template for breaking apart the activities within your clinic and identifying what you do and where you need more skills, maybe reviewing 12-lead ECGs and being a bit task-orientated because it may be taking clinical history, blood results and so forth. Timing that, what are you going to do about that, how are you going to demonstrate achievement, a simple framework, but just getting people to stop, work within your scope and think about how am I going to best meet the patient's needs. In the UK we often say, are you going to consider becoming a nurse prescriber? No, I don't feel comfortable with that, but it's something I may think about in the future. You know, nobody wants to force anybody to do anything that they feel uncomfortable with, but just to think how you're going to professionally develop, not train. You train a dog, professionally develop. It's about education and development. Managing medicines, how's that going to be achieved? Is it the GP signing? Are you going to be a nurse prescriber, or however it works? International comment, really. In the UK, we have independent prescribers. That's a slightly old-fashioned phrase for us now because we used to have what they call patient group directions as supplementary prescribers, which meant a care plan was written up and you followed it without a doctor's prescription, all this sort of thing. But now we have achieved what we call the V300, which is our 6-month course on independent prescribing. But it's something, it could be the weak link in the chain of the patient pathway. And importantly, audit and evaluation, which I could speak for days. We've had other speakers who said they could speak for days on their thing. I could speak on audit and evaluation. I split it into two for you there, just to think about audit and evaluation. I know they are overlapping, but it's quite nice to split them and give a clearer, not precisely accurate, but you'll get the point. Audit to me is counting. How many patients did you see? When did the clinic run? Did you give the patient this particular information, etc.? Evaluation is the merit and worth. Are you making a jot of difference to anything with these patients? The quality of life, readmission rates maybe, physiological parameters, patient experience, etc. How are you going to measure the effectiveness of your clinic? That's the world we live in, financial world, professional world. We have to demonstrate effectiveness. So I sometimes say I particularly do the split for when I've got students doing essays and things, you know, I think about you keep talking about this model and you've kind of audited it, but does it make any difference? Is progesterone declemente useful? Is the health belief model useful? Is this, that and everything else useful? Has it been tested in nursing? Is that a business model that comes from the business world, is it good for leadership in nursing? So evaluate, does it make any difference? And finally, closing the loop, simply saying, you've audited, you've evaluated, what's the action plan? How are you going to grow? How are you going to improve? How are you going to scenario plan? Who's going to take over from you if you're run over by a bus? We often ask that at our conference to say, you're a fantastic nurse running this clinic. What would happen if you left tomorrow? Who would take over? Would it go back to being doctor-led? And now we're getting, saying, I've got some great practice nurses who are working with me and they're prepared and they're developing in that area, etc. But just closing that loop. I won't go through all of these, but you can have these slides because there's quite a few of them. There are many templates for creating a business case. I'm no good at adding up, so I always, when I have to do funding things, we've just got £63,000 from one of our sectors in London that provides the funding for medical nursing and allied health education, £63 to provide education for our bands 1 to 4. They're our unregulated healthcare assistants to provide better end-of-life care for patients in the community. Ideally, so that they die in their place of choice, whether that's home, hospice, or whatever, because that's a little bit of a problem for us. And when that was put together, the finances, you have to have help, so you have to have a finance person, but you might be a whiz kid on that and be able to rustle it up and get a nice accurate. I can't do that. You might be somebody who's great at doing business plans, comfortable with it. You might be up at the midnight thinking, what the heck does this all mean? That's absolutely fine. It's knowing the limits and looking for help. That's all you can do, because at the end of the day, they're interested in a good business plan at the end, and how you learn on the way is up to you, really. So we say the importance of it is its survivability and pitfalls. It allows you to think ahead. It allows you to plan and think critically, if you're honest. Maybe this business plan will say this isn't the right time for the clinic. Maybe it's saying it's not the right time, but we've got to do it. So at least I know what I've got to do and how I can make it most successful. And it can assist in the auditing process. Remember, it can be for a number of people. So do think about how it's written. And remember that the executive summary, which we tend to write last of all, may be the only thing that some people will read when they're getting a quick overview of what it's about. They may not read the other 10 pages or whatever. So, various templates. Executive summary is just a short, sharp overview, which sets the scene. Within it, your vision, your mission, your objectives. Short, medium and long term is useful, otherwise you're waiting forever to achieve a goal. So it's nice to have some short-term goals as well. Who's going to be involved? What are you offering? And a SWOT analysis, strengths, weaknesses, opportunities and threats. And if you can do that with the team, it makes it inclusionary, but also it makes it more valid and realistic, because what's a strength to you may be a weakness to somebody else, and so forth. It's got to be as valid, as truthful as possible. It's from the business world, so what's the competition? I.e., is everybody else setting up the same clinic and you're going to do all this effort and you're only going to see 2 patients a month? You don't want to run a clinic for that, but you also want to make sure that you're offering something to the 2 patients who can't come to the clinic because you're not running it. But just have a think about, is there really a market there for this? And if not, what else are you going to do? Patients, are they growing in size or shrinking? And where are they? Are they going to be able to get in? We've just done some research on congenital heart disease, nurse-led clinics in the UK. It's coming out in the International Journal of Nursing Practice, probably out this month, I think. And that group is growing, estimated by about 2,500 nationally a year, because over 80% of patients, certainly in the UK, with congenital heart disease live to over the age of 18. So they're surviving, so they're growing based on the birth rate. How will you promote the clinic? Again, the location. Further market approaches to keep the momentum going. Yes, expected market share, numbers, etc. Again, as you can see, that's why I love Lynn's document, because that's designed as a business case specifically for clinics. This is kind of taking a template from the business world. Finances, what will you need to run the clinic, and procurement, funding, office space, stock. They're all things you need to think about. Finance requirements may be summing up the other sections, but what funding will you need? Be as precise as you can and get some help on that, if it's something you're not used to doing. Because we originally weren't trained. We're trained as nurses. We're educated as nurses. See, even I keep saying that awful word. Business controls, quality controls, standards for us, the QOF framework. How are you going to demonstrate that you're providing a quality service? How will you fit these in to running of the clinics, the computer systems and so forth, to make sure the patients are getting their evidence-based care and medicine? And finally, evaluation. Wise to outline briefly how you'll demonstrate the effectiveness of the clinic. So you're thinking ahead as to how you're going to do that. It doesn't have to be precise, but it might be patient experience, might be quality of life, and so forth. So we think about the patient criteria, as we said, the publicity, the location, multidisciplinary support, professional development, managing medicines, audit and evaluation, and closing the loop. I haven't said a lot about measuring effectiveness. That wasn't what I was asked to do, but I do a separate session on that. But I would just say that we are moving, particularly in the UK, but it has been a national argument for some time, to measure patient experience and not satisfaction. So I just want to kind of put that seed in your mind. It's okay, satisfaction, but you don't want it to dominate the way you're collecting your data if you're looking at patient experience. It's very hot on the agenda in the UK because of the Mid Staffordshire NHS Foundation Trust scandal, which was a high profile. It was actually mentioned by Rosemary this morning, so you think, oh crumbs, they found out. But it was a very, very significant. Well, it's a shameful thing. It was a scandal in the UK. And I would expect somebody like Rosemary to know about that because it was a significant event. Probably the worst scandal in the NHS. Staffordshire Hospital, it originally was patient complaint from 2008, and they did an investigation and found a very poor culture. As Rosemary was saying, patients drinking from flower vases and in their own excrement, and it was a terrible thing. And you can see a lot of the reports on the web, and it led to the Francis report, Robert Francis QC, who said, as Rosemary highlighted this morning, that leadership was lacking at all levels, bad culture, understaffing, and a focus on outcomes, and really the patient voice wasn't being heard. So we need to think about the process, how we do things, what might be termed the relational outcomes, as well as the transactional, what outcomes we've got, but how we're getting there, it's very important. So, experience and satisfaction. This goes back quite some years to very eminent researchers such as Thomas Del Banco. He's Professor of Primary Care and General Medicine from, the moment, I think, the Harvard Medical School. And people like Susan Edgman-Leviton, who's currently works at the Massachusetts General Hospital, and she's their Executive Director of their Primary Care Innovation Centre, and was one of the founders of the Picker Institute, which is an institute which you may have heard of, but we use a lot of their patient surveys within the UK, a highly respected organisation, Picker Institute Europe. And they said, satisfaction is not the most ideal way of measuring patient experience because satisfaction is an emotional response. It's not easy to tie it to a quality standard, and patient satisfaction varies. And I've given you some references at the end here. Generally, older patients tend to be more satisfied than younger patients, different ethnic groups, etc. And I've given you some of those references and research to show that. But also, if somebody says, I'm satisfied or I'm not satisfied with the service, if they're not satisfied, what are you going to do about it? It doesn't really tell you what's happening and what to change. So it's much better to focus on what happened to the patient rather than, are you satisfied or not satisfied? So how polite the nurse was speaking to you, how involved were you in the care, the cleanliness, etc. Were you able to ask questions? Were your family involved? All these different experience questionnaires, question points. In the UK, we have PREMS and PROMs. We have patient-reported outcome measures, which at the moment are disease-related, hip replacement, knee replacement, etc. And we have patient-related experience measures. So we have the General Practice Assessment Questionnaire. Ipsos Mori do a community or GP survey. I think they survey about twice a year, 1.2 million patients. I'm not saying they get that back, but that's who they survey. And the General Practice Assessment Questionnaire asks about the last nurse you saw, the receptionist and the last doctor you saw, and asks about those relational aspects. the King's Fund and the Health Foundation in the UK, and I brought those documents for you over from the UK, because of all that's been going on in the UK, have produced excellent documents recently on the pros and cons of measuring patient experience. The King's Fund in 2010 with Dr. Foster, another highly respected research group, for want of a better phrase, in 2010 did a document on patient experience and how best to capture that. The Health Foundation 2013, another one on the pros and cons of different approaches, and Emma Pennery's chapter in the book. So there's a lot on how best to capture that. But satisfaction is a very personal thing. It doesn't necessarily reflect on the quality, and some people are quite satisfied with low quality, and some people are not, as TripAdvisor will tell you. So there's different ways of looking at satisfaction. It's not the best measure. A paper came out in 2004, which I'm not sure I've got, and I can't remember who wrote it, but I can access that if you need that, that also showed that even then patients will kind of adjust their responses, because they say, oh, well, I wasn't very satisfied, but nurses, they work so hard, and they're underpaid, etc., so I'll give them a higher score. It's very subjective, so it's better to say what actually happened within the clinic. So satisfaction, I see a lot of it still. Let's do a patient satisfaction survey. It's not the best method, and I've given you some references, it's worth trying to focus more on patient experience. Finally, I have to mention organisational and wider culture, because it impacts on so much that we do. And what I'm talking about our experience, is about changing culture in the UK. As I've said, we don't regulate nurse practitioners, you do, so it's not me coming over in any shape or form, it's sharing. It's long gone are the days, even though Florence made an appearance at some point today. That's a long time ago. We've got some good things and some bad things, and it's now a global community, as organisations such as the International Council of Nurses rightly demonstrate. So we've got some good things and some bad things. And you're an all-graduate profession, of course. And does anybody know when we achieved all-graduate status in nursing in the UK? Last September. Last September we went to an all-graduate profession. We have not been able to achieve it until then. And people say, last September? That's absolutely true. And the last diploma nurses started last January. We got rid of enrolled nurses in the 1980s, so that may have been something to do with it. But we tried from the 80s onwards to go to diploma to degree, and we've just achieved that now. And even then, it's a little bit of a struggle, because the demand for nurses always outstrips supply. So we've always had degrees, but an all-graduate profession, we've only just achieved that. So you've been there since, I think, 84, a long, long time. We have been unable to achieve that. So, it's a little bit of swings and roundabouts. So you'll probably stop listening to me now. So organisational wider culture, it's a good point to do this on the second day, towards the end of the second day, because I can bring these two tools in, which are helpful in operationalising. I'm quite a practical person. They may or may not be useful to you, and you may have seen them before. So organisational culture, I mean, I'm not the expert that Stuart would be, and he'd have lots of great definitions, but I give you those that mean something to me. The values and beliefs of an organisation, the way things are done round here, of course, and the one I heard only a couple of weeks ago, which is my favourite, as Lynn knows, is what people do when no one's looking. So I quite like that one. Probably terrible things. But that is about buy-in, where somebody's saying, it might be the mission statement, it might be what we're putting forward in the annual report and to the patients, but what's actually going on every day, what's valued, etc. The cultural web, I brought the book with me somewhere, originally emerged in the early 90s, and the latest edition is 2012, and that helps us in our individual practices. It won't provide you with the answers, but it'll help you break apart what the culture is, because sometimes it's things, I think Stuart was talking about symbols, and there they are, things that you sometimes can't, it's not very tangible, but it's so powerful. As Stuart was saying yesterday, if you worked in a toxic culture, etc., we've all been around a while. I'm sure we've worked in great places, not where you just can't get things done, where you're watched, where nobody's encouraging, all sorts of nasty things, and other places where it just, sometimes when it goes well, you can't even pick it apart. I just feel valued, and I feel I can make changes, etc. So all of those areas make up the paradigm, which is the culture. And very quickly, what this text from Johnson et al. Ask us to do, they ask us a set of questions, which again on a slide I can't necessarily praise you very easily. Ask us about each of those set of questions, then ask us what the changes we want to make, and then ask us what we would need to change within each of those areas to move forward and successfully bring in that change. Doesn't mean we can change it, but at least it allows us to work ahead on those. Stories are what's said about the organisation to newcomers when they arrive, what the coffee room chat is, what the behind-the-scenes chat is, not what we're necessarily saying formally, but about who you go to get things done, what you can get away with, what you can't get away, all this type of thing. What is the actual workings, the truth of the organisation? Stories also put the present in the past, or the past in the present. Oh, we've always done that because when Jo was here, she liked Jo, and that's kind of how it's always been. That type of thing, how it's always been. The symbols are the unspoken, as Stuart said, where the parking space, the doors that are closed, the uniforms, the way the offices are set out, whether somebody's saying to you, I'm always available to talk to you, and their door's always closed, the contradictions, those types of things. The power structures, who you go to, you all recognise that. The power structures, who you go to, who are the movers and shakers, even informally, who actually is the person, may not be the person at the top, but the person that oils the wheels and gets things going, etc. Organisational structure, the roles, the responsibilities and the reporting. And I better not be as honest because I'm being filmed, but I've worked in organisations where, I've had bosses who always say, CC me into everything. Other places, my last university, I don't think I filled in an annual leave card for 9 years. They were very, very trusting, and I was to be trusted. I didn't take extra or whatever. But my boss would talk to me and say, "That sounds a great idea. That's where we want to go. If there's any problems, come back to me." And I had a lot of freedom, very flexible working hours, and all those sorts of things. The reporting was much looser, and that links to democratic decision making, trust, and those sorts of things. Control systems. What's measured, and what you're allowed to do, how appraisals work and those sorts of things, and what's monitored and so forth. Routines and rituals might be how we promote people around here, who sits on which meeting, who's on interview panels, all that sort of thing. So that one, in the time we've got, is an interesting one if you're trying to think about. They keep talking about culture. How can I make it more tangible, and how can I possibly change this culture? So there are some tools that don't give all the answers, but might be quite useful. And finally, of course, if you've seen it before, the force field analysis, which dates back to the 50s and is highly useful in clinics and other areas where we've got a change that is significant, sometimes not so significant. And Lewin argues that change produces resistance, yes, as we know, and it's a balance between the forces that drive it and the restraining forces. So what you do with this, and it's a nice simple paper and pen exercise, I've used it 3 times, you may work with a team to say, look, we've got this change coming, and it helps because it includes everybody, and that, it's like a transformational leader. It's saying you're all valuable, I want to hear your opinions, rather than this is going to happen. Sometimes what I call when I do my leadership stuff, the seagull manager. The manager you don't see very often comes in, flaps around, drops something nasty, and you never see him again. That's the seagull manager. That's not the person you want leading you. You want somebody who's there with you all the time. So the driving forces might be within a clinic, individual to you. It might be that the multidisciplinary team want this. We've got the location to do it. We've got the office space. We've got the admin team on our side. We've got the skill. Absolutely fine. Restraining forces might be, there's only going to be about 3 patients we're going to see. Is it worth doing it? It might be that we've got some people who won't accept our referrals. Finance-wise, it's not going to work, etc. So you work through them and you rate them, strong, medium or weak. The idea behind it is you take your restraining forces, particularly your strong ones, and it gives you time, rather than firefighting as you go along, to see the wider picture, to see what might resist, and to work on those, to go and talk to people, to perhaps set up the education for the nurse so they don't feel, oh crumbs, I've got to run on a course and learn how to do this, to be able to more effectively manage the implementation. The important thing about it is that the team are involved, otherwise it just becomes valid to you or to 1 or 2 people. So involve everybody that you can. Remembering within a group that often, and very rare at the time, within a group that some people may see a restraining force as a restraining force and others see it as a driving force. When I put nurses back into the community, students back into the community after a gap of about 18 months, I said we did this analysis, and I said one of the big driving forces to community nurses is they're only going to be with you for 4 weeks twice a year, so they're not going to interrupt you too much. And they said that is a big restraining force. You're wanting us to do an assessment when they get there, a midpoint and a final assessment in 4 weeks. We won't even told them where the fire escapes are and where the paperwork is within a week. We need them for a good 2 or 3 months to be able to do that. I thought it was a driving, they thought it was restraining. So there is the risk that you've got to come to a consensus. The other is in a group where people don't necessarily speak up. You can do this by actually giving them a paper exercise. They could do this and put it anonymously in a box if you're worried that people won't be honest because the boss is watching and this sort of thing, and collate it and then bring it back to people and say anonymously we've got a nice valid picture, because some people in a group won't speak up, be a bit worried about speaking up. So you can get them to be more honest, or turning over cards with different things on to say what the restraining and driving forces are. I've used it 3 times. Planning ahead, it's an inclusionary model. It allows you to go away and think, right, I never knew that was going to be a problem. Let's start working on that so that we can move this forward successfully. So, to sum up there, I've given you a little bit of the UK context, some of the evidence, which you're very welcome to use. We've gone through 10 sort of key areas that might be useful as a framework to think about. And we've also gone through how to do a business plan, the importance of the aims and objectives as well, and also highlighted there for you organisational culture, which a little bit of lip service, but I hope the timing is right when we're talking more about the bigger picture of organisational culture, that there are a number of tools out there. Lewin, easily available on Google. It's a well distributed tool. Cultural Web may be less commonly seen, although it is on the web and might be useful to help you put in place nurse clinics. But I know it's not easy. And just a final point, I've always said the same thing, not every nurse can run a clinic. It does take, and I think everybody else in this room would agree, but also would be able to do it. It does take a special person to run a nurse-led clinic effectively, and I've seen them around the world, but not every nurse can do it. It does take a particular, I think, drive, skill, etc. But thank you very much. The references are there if you need them and when you get the slides, etc. Sorry to overrun a bit, folks.
Does anyone have any questions for Richard, please? One here at the front.
Just wondering whether the nurse-led clinics in the community and the shopping centres and whatnot, are they also restricted to people that live within that postcoded area?
No. Do you mean for the patients who come in?
Yeah.
No, not at all. It's a fairly new initiative. So Victoria Station, which is my big station near where I work, there is an NHS. There'll be GPs there, but there is privately run nurse-led. So it's anybody who wants to come in. So there's that's in the private sector. The NHS walk-in centres, to my knowledge, which are nationalised, aren't. They're one stop because they would refer them back to their GP. They only see them once. They're not postcode limited. It's a very good question. Your GP practice is. You can, if you came over or I was in another city in England, the GP wouldn't say, I'm not going to see you. They would definitely see you, but they would write to the GP and say, now you need to go back there. The postcode restriction is just, for numbers, etc. There's a lot of people in the UK. But certainly NHS walk-in centres are not, I may be corrected, but are not. And the private kind of airport things, which are privately run. I mean, they cost a lot of money. You can imagine you go in there and you see a doctor and you've got to pay 50 quid for your antibiotic or whatever. But they're anybody can come to those.
No questions, just 2 comments. I note that you went to your GP and you got a script for Ventolin. One of the good things here is that you don't actually need a script for Ventolin in New South Wales. You can just walk in and buy it off the chemist.
Yes.
So that's empowering people to manage their own disease. And the other comment was about the increased admission rates for those nurses in the COPD clinics.
Yeah.
It's our experience that nurses will often identify aspects of that patient that they actually require hospital admission. So more of the social aspects,
Yeah.
that we're not sending this person home because there's no one to go home to, or
Yeah.
the person that's looking after them is not there, blah, 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 blah. So there'll always be that, so people come into hospital for nursing care.
Yeah, I think
But
that's
not
a very
medical
good
care.
point, and it's an interesting one with the COPD. It's whether you're comparing the same type of almost assessment, so the nurse may be more holistic and picking up other things, and it's taking more time. I think you're absolutely right that definitely we need to dig deeper into what's happening there, and not necessarily thinking that is a negative thing, because nursing will offer something a little bit different, maybe a bit better, more holistic, etc. To that point, one of the problems with, there is a recent report on, as I was saying, on the effects of the QOF, the Quality Outcome Frameworks, and there is a concern that it's driving nurses a little bit towards targets and not towards holistic. And some patients in that report are saying, chronic ill health, I'm not getting the holistic service that I would like because it's driving them towards targets. So yeah, thank you for that. We definitely need to dig apart that more.